Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. In this video, I would like to discuss the initial assessment, management, and monitoring of patients with head trauma at the scene of injury, during transport, and at the emergency department before admission to intensive care unit. Traumatic brain injury is a critical condition, and the main aim to achieve in the early stage of management should be to treat the life-threatening emergencies from the primary injury and to prevent or mitigate the risk of secondary brain injury, which is mainly caused by hypoxia and poor cerebral perfusion. To assess patients with traumatic brain injury in the first instance, history taking by the ambulance crew at the scene of injury is a key component, and also the eyewitnesses play a major role for the ambulance crew to collect the bits and pieces of information from a variety of sources and to understand the overall picture of the mechanism of injury and the condition of patients when they are first found. Immediate life-saving treatments are as important as obtaining vital information, especially if the patient's GCS is falling. Therefore, treatment must not be delayed for detailed history taking. The best thing to do is to prepare a checklist of prioritized essential information which we would like to gather. As intensivists, we tend to get history from the ambulance crew and emergency doctors. It should include time, place, and mechanism of injury, vehicle speed, whether the drivers and passengers use seatbelts, airbags, and helmets, whether they are under the influence of drugs and alcohol, any possible medical reason for the accident, for example, cardiac arrest, myocardial infarction, seizures, or stroke, the conscious level of the patient, that is motor score of GCS, which could be of prognostic benefit as I mentioned in my previous videos, and pupillary response, as well as the vital parameters at the scene and on the way to hospital. Estimated blood loss, treatments given so far, past medical history, and if patients are taking anticoagulant or antiplatelet medications. The main causes of death in a trauma patient are airway obstruction, respiratory failure, massive hemorrhage, and brain injuries. The primary survey includes ABCDE assessment, and it should be done quickly to recognize and treat the life-threatening injuries at the scene and after admission to ED. It is important to prioritize the injuries according to the information gathered from history taking. Let's start with A. Airway. In patients without any airway reflexes or with abnormal pupil responses, we should secure and maintain the airway by trachea intubation as soon as safely possible, particularly when trained and skilled personnel are around and transport times are long. Despite possible complications of trachea intubation, the adverse effects of transferring patients with severe head injuries and compromised airway could cause more harm towards the patients. We should also consider intubation in patients with higher GCS who are having associated injuries which could put them at risk of hypoxia, hypercapnia, or progressive hypotension. Rapid sequence induction is the recommended technique using cardiostable agents such as ketamine, fentanyl, and fast-acting muscle relaxants like rocuronium or succinylcholine. During intubation, we should always think of possible cervical spine injuries and minimize the risk of further neurological damage. Hence, an extra person will be required for manual inline stabilization of the cervical spine. The application of cervical collar could be considered in patients with high risk of cervical spine fracture, for example, road traffic accidents and falls from great heights. However, bear in mind that hard rigid collars could increase intracranial pressure, so we need to be really cautious in patients with traumatic brain injury. We should assume all patients with head injuries have cervical spine fractures and treat them accordingly until such fractures can be ruled out radiographically. After intubation, early use of capnography is strongly encouraged to confirm the trachea tube is in the right position and to keep an eye on the end-tidal CO2. When the tube is confirmed in the trachea, we can start to optimize the ventilation and oxygenation. All patients with traumatic brain injury should be given high-flow oxygen, and if they're not intubated, we should provide oxygen via face mask. Ideal SpO2 target is more than 94%. However, lower SpO2 values more than 90% may be acceptable to avoid potentially harmful effect of high PEEPs and lung recruitment. In early phase of brain injury, hyperventilation of the patients should be avoided and PaCO2 should be kept around 4 to 5 kPa. Please avoid hypercapnia at all costs. If there is any evidence of severe intracranial hypertension, it may be life-saving to hyperventilate the patients to keep PaO2 as low as 3 kPa while awaiting surgeries to reduce ICP. Even so, it should be carried out only for a short period of time, probably less than 30 minutes, because prolonged hypocapnia could be related to cerebral ischemia and poor outcome. During hyperventilation, we should consider to give 100% oxygen to the patients to prevent cerebral hypoxia as much as possible. From circulation point of view, hemodynamic resuscitation should be initiated via fluid administration and vasopressors if systolic blood pressure fails to improve within minutes after adequate volume replacement. If the patient is hypotensive, we should check for extracranial injuries, since intracranial injury alone does not commonly cause hypotension in adults, unless head injury is extremely severe, leading to bilaterally fixed and dilated pupils. Sedation and mechanical ventilation could contribute to low blood pressure as well. To maintain cerebral perfusion, target systolic blood pressure in younger adults should be more than 110, and in elderly patients, we should aim for systolic blood pressure more than 130, or mean arterial blood pressure around 90, if there is no suspicion of having penetrating injuries and internal bleeding. In actively bleeding patients, target of systolic blood pressure around 90 would be reasonable for permissive hypotension to keep blood pressure low enough to avoid exsanguination, but high enough to maintain organ perfusion. To achieve target blood pressure, fluid should be administered, aiming for normal volemia. In patients with traumatic brain injury, 0.9% sodium chloride is preferred to balance crystalloids like Hartmann's solution. Fluid resuscitation can be guided by assessment of fluid status with clinical examination, lactate and SvO2 in blood gases, focused bedside echo, and pulse control cardiac output PICO studies. Colloids, including albumin, and also hyper or hypotonic solutions are not recommended for fluid resuscitation. If increased ICP more than 20 mm mercury is a concern, we should consider using mannitol or hypertonic saline according to local protocols. Generally, mannitol is a potent diuretic, hence in patients with hypovolemia or hypotension, hypertonic saline may be a better option. During osmotherapy, serum osmolarity, blood pressure, and electrolytes must be monitored closely. While we are stabilizing the patient's cardiopulmonary status, we should keep reassessing their neurology and response to the treatment. Moreover, we need to ensure the blood sugar level is within normal range. During exposure, both intracranial and extracranial injuries should be identified quickly. Bolus dose of 1 gram of tranexamic acid followed by 1 gram infusion over 8 hours is evident to reduce mortality when started within 3 hours of injury in patients after polytrauma, because tranexamic acid is antifibrinolytic and it may mitigate the clot breakdown and the injury response inflammatory pathway, which could lead to endothelial permeability, tissue edema, and bleeding. In bleeding patients, balanced transfusion of blood products, that is 1 to 1 to 1 ratio of packed red blood cells, platelets, and plasma, should be commenced early without waiting for lab results. According to recent studies, target HB should be around 90 gram per liter. If the patient is taking oral anticoagulants, warfarin for instance, IV vitamin K and prothrombin complex concentrates are suggested to reverse the anticoagulation effect. For direct oral anticoagulants, which are commonly used in the UK, such as apixaban, rivaroxaban, or edoxaban, there is no specific antidote available, so prothrombin complex concentrates and fresh frozen plasma could be helpful in this situation. Specialist opinion of hematologists should be always sought to manage patients on DOAC with severe traumatic brain injuries. So far, there is no specific guidelines for brain-injured patients who are taking antiplatelets. All possible measures should be taken swiftly to stop bleeding, for example, compression of external bleeding sites or limbs, compression of the pelvis via pelvic binder, etc., and, if required, we should arrange for urgent angiography with embolization or damage control surgery. Hypothermia could derange the clotting system, resulting in prolonged uncontrolled bleeding. Therefore, should be avoided by covering patients properly after physical examination and by the infusion of warmed crystalloid fluids or blood products. Continuous monitoring of vital signs with capnography if the patient is ventilated, pulse oximetry, 3-lead ECG, non-invasive blood pressure or invasive blood pressure monitoring with arterial line is vital for patients' safety. Neurological monitoring like ICP device, EEG, evoked potentials, transcranial Doppler, tissue brain oxygenation can be initiated in ED or in operation theaters at specialist neurocenters. Basic laboratory investigations such as full blood count, UNEs, creatinine, liver function test, bone profile, coagulation profile, thromboelastogram known as TAC, blood group and safe in bleeding patients, creatinine kinase, troponin, and amylase lipase in polytrauma patients should be sent as soon as possible after hospital admission. Arterial blood gases should be done to monitor pulmonary gas exchange and metabolism. Furthermore, initial radiological investigations like X-rays of chest, pelvis, and lateral cervical spine, and abdominal focus assessment with sonography for trauma, known as FAST scanning, could be performed as well while continuing resuscitation care. Bedside transthoracic echo could be helpful to identify neurogenic pulmonary edema and cardiac stenting due to catecholamine storm caused by acutely increased ICP. When the patient is stable enough to transfer to the scanner, full trauma CT scan, which consists of CT head, cervical spine, thorax, abdomen, and pelvis with contrast, thoracic and lumbar spines, should be done to not miss any important injuries. CT head should be repeated within 12 to 24 hours, or earlier if clinically deteriorated, in patients with traumatic brain injury on DOAC. After completion of the primary survey, we should move on to undertake thorough head-to-toe examination, which is the secondary survey. Starting from the top, we should inspect and feel the skull for any wounds, blood clots, palpable fractures, and signs of basal skull fractures, such as periorbital hematomas, bruising behind the ears, CSF rhinorrhea, or otorrhea. Open injuries of the skull, any foreign bodies, facial and eye injuries should be also identified. Breathing pattern of the patients should be observed, especially when they are conscious. Abnormal respiratory patterns, Cheyne-Stokes respiration for instance, could indicate severe neurological damage due to increased intracranial pressure. The main aims of neurological examination in awake patients with traumatic brain injury are to determine the level of consciousness via GCS score and pupillometry, and to recognize any focal or lateralization signs via full neurological examination whenever possible. I've discussed GCS scoring in detail in one of my previous videos, so if you're interested, please click the link in the description below. Regular neural observation and careful documentation is critical to the detection of neurological changes. A significant neurological deterioration is considered a decline of GCS of 2 points or a new abnormality in pupil size of reaction to light, or an evolution of CT scan. It could be a useful guide for repeated imaging and clinical decision-making for intubation and ventilation, neurosurgery, or ICP monitoring. Whilst the patients are being resuscitated and stabilized after traumatic brain injury, the senior member of the staff should speak to the relatives as soon as possible to update the patient's clinical situation. Prognostication should be guarded at this stage because the situation may change rapidly. Therefore, comments on patients' conditions should be limited, and we should focus on the immediate plans for treatment. Additional important clinical information, for example, a patient's baseline physical status, any background comorbidities, or regular medications, could be obtained from the family as well. We can provide reassurance that patients are in good hands and aim for regular updates on the progress of the patients. That's it for early assessment and management of patients with traumatic brain injury. Hope you have learned something new from this video. If you have, please share with your friends and colleagues. In the next video, I'll discuss the indication of neurospecialty referral, causes and pathophysiology of primary secondary brain injury, assessment, monitoring, management, and complications of patients with severe traumatic brain injury in neurointensive care unit. I'll see you soon. Take care.